The patient.
Okay, if you're not careful, please, you make mistakes. So
Then you place the tube in the water.
Into water, some bottle.
no,
Yeah.
no, please, no. It is two things. When the tube dislodges from the patient's chest wall, you place your gloved hand whilst you prepare for reinsertion. When the tube dislodges from the drainage system, you put inside a bottled
A
water.
bottle.
Please get the difference. Okay, please
Please
get
come
the
again.
I said that when the tube dislodges from the patient's chest wall, you place your gloved hand on the chest, the insertion site to prevent air entry. And then when the tube dislodges from the drainage system, then you have to do what? You have to now place the tube in what? In bottled water. So please take note. Don't confuse the two. All right. Is it clear? I'm sure it's clear.
Yes, sir. Thank you.
All right. You're welcome. So please, the chest tubes is very important. In fact, if you forget anything about pneumothorax, it shouldn't be the chest tubes. And then also, you should also try and know the key signs and symptoms. Okay, deviation of the trachea, subcutaneous emphysema, shortness of breath. These are key signs of what? Of pneumothorax. Okay, so please let's take note. If you want a recap, just go to the YouTube channel. Every video is there. Okay, all the videos for the respiratory system so far are on the YouTube channel, so you can just listen to them. Please, let's not come to class and forget. And then some people, when they come to class, they are more interested in writing a lot. They are more interested in taking screenshots of my slides a lot more than listening. So they will end up going back for the recording. For me, it is better to pay attention, understand everything right in class. You don't worry yourself to go back to recording because see you the NCLEX and the thing you are learning for the NCLEX is a lot to it's plenty. You know the book that we give to you for you to print. You just look at the size of the book. You have to read that book at least one or two times, sometimes three. Okay, times before you sit for the NCLEX. So please, when you get opportunity to learn, you learn once and for all. So let's pay attention. Let's get it right on spot. And then maybe even if you go for the recording, it should be maybe something like more of quick revision, not using all the time as well for the recording. Okay, so please, that is that. That is that. All right. So we are beginning today's discuss. May God help us. Amen. All right. Tuberculosis. Ideally, I'm sure I am recording. Yes, I am recording. Good. Ideally, tuberculosis should be under infectious diseases. Okay. When you talk about tuberculosis should be about or under infectious diseases, not under respiratory system. But then, because it is common, because usually sometimes you begin to get issues with the lungs. I decided to chip tuberculosis in. Okay. So please let's deal with tuberculosis, then move on to pneumonia. Okay. It is not broad. And then the tuberculosis, our focus will be mainly on the diagnostic test and then the drugs. Okay. Let me put it that way. And the drugs. Okay. So please let's try and capture those ones very well. Though everything is important. All right, let's start TB. Let's start TB. So for TB, it's a common condition that we all know. We all know TB. We all know tuberculosis. Okay, so TB is a bacterial infection caused by Mycobacterium tuberculosis that primarily affects the lungs. Okay, so the pathophysiology, what I would say is that maybe you find yourself in an environment with someone infected with the bacteria. Okay, the name of the bacteria is the Mycobacterium tuberculosis. So when a person coughs, when a person sneezes, sometimes it is surprising. They say that Even when a person laughs, you can get TB. Okay. So by way of coughing, by way of laughing, by way of, let's say, sneezing, the bacteria finds itself in the air. Okay, the bacteria finds itself in the air. And let me tell you something. Any condition that is caused by airborne, it means that the bacteria causing it can sustain in the air for long. That is why it is airborne. Any condition caused by droplets, it means that the organism or whatever thing causing the condition, it is quite heavy, so it doesn't sustain the air for long. It is the moment the patient cough or whatever, it drops. Okay, it drops, and then you get in the contact by what? By droplet means, or by touching surface or the rest. Okay, so that is why. So this condition, this bacteria, it is not that heavy. It is light. Okay. So you can sustain in the air for long. That is why it is gotten through airborne transmission. All right. So a patient coughs. Okay, when an infected person coughs or sneezes, they release the bacteria into the air. Then this bacteria can sustain the air for long. So you want to pass there, or you are close to the person. So when the patient cough, you inhale the bacteria. The moment the bacteria gets inhaled, the moment the bacteria gets inhaled, they reach the alveoli. Once they reach the alveoli, they begin to cause inflammation. This inflammation causes the release of immune cells. I mean, a lot of inflammatory mediators, causing the immune cells to become what? Aggravated. Okay, so normally we get cells like the macrophage and all these things. They will be released, right? So once these are released, they begin to multiply. Okay, they begin to multiply. So the bacteria becomes difficult to what? To be destroyed by this inflammatory, because once they are released, some way, somehow, they help the material to become multiplied. Once they become multiplied, they begin to colonize your airway, and they begin to cause issues like coughing, like night sweat, and affect your immune system, weaken your immune system, and the rest. Okay, so that is how TB usually comes about. Someone will inhale will cough. An infected person will cough. Once they cough, what is going to happen? You will inhale, or someone will inhale. Once they inhale, the bacteria goes deep to the alveoli. Once they get to the alveoli, there's release of immune cells, the release of inflammatory mediators. Okay, they begin to try to fight the bacteria, but sometimes the bacteria is difficult to fight, especially when patients they have a weakened immune system. If the patient have a weak immune system, or if the person is very very consistently has been inhaling to the point that it doesn't have the strong system to counter the bacteria, they begin to colonize your airway, colonize your body, begin to affect and even weaken the immune system further. Okay, then you begin to present a signs like cough, signs like a night sweat, and so forth and so forth, that we can find as signs and symptoms of what? Of TB. Okay, so that is all you should know about the simple pathophysiology. Okay, it is not something, I mean, broad or something special when it comes to tuberculosis. You just inhale the bacteria begin to colonize your airway or colonize your body, begins to weaken your immune system. You begin to present with the various signs and symptoms that we have. Okay, all right. So that is that. Then we have types of TB. We have pulmonary TB. We have extrapulmonary TB, latent TB, and active TB. So the pulmonary TB affects the lungs. Okay, we will say that the pulmonary TB affects the lungs. Then extra pulmonary. Okay, pulmonary stands for lungs. So pulmonary TB means lungs. Then extra means aside the lungs. So TB that affects other parts of the body, like the kidneys, like the spine or the brain. Okay, the kidneys, the spines, and then the brain. Okay, good. Then we have latent TB. Latent TB, the bacteria are present in the body, but the individual is not sick and cannot spread the disease. Okay, therefore, we have active TB. The bacteria multiply and cause symptoms. Okay, so as I was trying to explain with the what do you call it, the pathophysiology, when there's release of this macrophage, and then the rest. Okay, they begin to cause the bacteria to multiply. You get it. When the bacteria begins to multiply, that is when they begin to cause the symptoms that you are going to you are going to get. Okay. That is something that you should know. Okay, good. So we will focus more on the latent and then the active in our discussion. The latent and then the active, not more on the pulmonary and the subpulmonary. All right, mode of transmission of TB. TB is spread through air when an infected person coughs, sneezes, or talks. Okay. So that is that. Any question? I doubt. Right. I doubt. So that is that. So causes and risk factors of TB. One, one. When an infected person sneezes, coughs, talks, or laughs, as I said. So it's a risk factor. If you find yourself in an environment in an overcrowded area whereby people are coughing, people are talking, people are laughing, sneezing, it becomes a risk factor, okay, for TB. Two, immunosuppression. So you have HIV, AIDS, and chemotherapy. When a patient has HIV, to the point that it progresses to the AIDS, the acquired immunodeficiency syndrome, whereby your immune system is weakened. How can you fight infection? Let me tell you. If you check a patient for TB, and then you do the skin test, which will get it very soon. We do the skin test, and then you get positive for skin test. But then the chest X-ray and the sputum are all negative. It could mean that the patient have a strong immune system. So the condition was not able to how do I put it? The condition was not able to progress. Was not able to progress to active TB, because all those you check the skin mantle test, and then most of the time they have the positive induration. Usually they have a strong immune system. That is why the condition was not able to progress to the active system. So many of us, I'm sure most of us are even here. We've worked in the TB unit before, or we've been working at the public health unit, the TB unit. We come across TB patients. Sometimes we don't even wear our masks. You imagine those who work at the OPD. A whole lot of patients are coming in, coughing, sneezing, but we don't get in the TB. Why? Sometimes we have strong immune systems, okay? So they are able to fight it. So individuals who have an immunosuppression by way of HIV/AIDS, by way of chemotherapy, by way of chemotherapy, please, what you should know is that they have immune system, weakened immune system, okay? That makes them liable to get TB. We all know that chemotherapy can weaken your white blood cells, right? Yes. So it predisposes you to getting hot infections like TB. 3, recent travel from endemic area. So if you just came from an endemic area, like you just travel from an endemic area, probably let's say an area, let's say Koforidua, there was an TB spreading throughout the area, and then you just travel from there. It's also a risk factor. Okay. 4, exposure to active TB infections. So you expose yourself to TB infections. That one too can put you at risk. Then 5, resident or employee of a prison, homeless shelter, and healthcare facility. So as I was saying, if you are the OPD, you stand a higher chance. Then if you are a prison officer, or you look over a homeless shelter, those homeless shelter, people who are homeless, they sleep around, they move everywhere, and they are being admitted, or they are being transferred to this homeless shelter. They come with a lot of diseases. So if you are not careful, they can transfer it to you. Okay, so if you are an employee at a prison, prison, how they overcrowd them. Most of us, I'm sure even all of us have been to prison before. We see how they overcrowd the prisoners. They can get disease easily, and they can transfer to what? You, the prisoner. Okay, and those at homeless shelter as well. Then 6, substance abuse, alcohol. Alcohol in general weakens your body. It weakens your immune system. It weakens the entire body. So consistent use of alcohol can even weaken you. Okay. Then 7, you have children at higher risk. Why? Why are children at higher risk? We all know that children usually don't have a strong immune system. Okay. Children don't really have a strong immune system. They are now growing their body. So they don't really have a strong immune system. So if they come around these areas, they stand a higher chance of contracting the infection. That is the TB. Okay. And sometimes they will say people who usually do what? Usually inject themselves, okay, also stands a higher chance of getting the TB, right? So that is that for the causes and the risk factor. Usually in case studies, you will see often individuals from homeless shelter. Okay, it's a key point. Usually they bring it a lot. So kindly pay attention. Okay, when you see things like homeless shelter and they are coughing, they are having, let me say, lymph nodes, they are having nice sweat. Okay, so please take note. Okay, of that. All right, next slide. Let's move on to the next slide. Good. So symptoms of tuberculosis. Symptoms of tuberculosis. Okay. We have one, latent TB. Latent TB. So 5 to 10% develops active if not treated. It means that if you get latent TB, for example, you have a strong immune system. Okay. So if they check you, you fall under the latent TB, and you don't treat it, please, it can still progress to active, but then usually it is rare. At least 5 to 10% of those cases of latent TB progress to the active. Okay, most of the time they don't progress. So at least 5 to 10%. So let's take note. And what should we know for the latent TB? They are non-infectious. They can't transfer the condition or the diseases. They can't transfer. They can't, infect anybody. So they are non-infectious. They are asymptomatic. You will not see anything like night sweat. You will not see like anything like chills. You will not see anything like a positive sorry, it's like weight loss, like chest pain. You don't see any of those things. Okay, you will not see anything of that sort, right? So please, let's take notes. Okay. All right, but then they have a positive PPD and blood test. Okay, they have a positive PPD and blood. We will get there. I'll explain why they have positive PPD, but then they still have that thing in the latent TB, right? So that is that. So non-infectious, they are asymptomatic. Okay, very good. Then the active TB, then this one, they are symptomatic, they are infectious, they have positive PPD. I mean, everything shows that these people have TB. Okay, these people have TB. So please take note. Okay, please take note. All right. So one, what symptoms should you know for active TB? What symptoms should you know for one, coughing? A persistent cough, often producing mucus or phlegm. Why? Because the bacteria is being inhaled into the airway. There will be inflammations. I think I've said this already under COPD. Anytime there's inflammation, there will be swelling, there will be mucus production. So the patient will attempt to compensate to bring the mucus out. Therefore, they begin to cough. Okay. So there's going to be a persistent cough, often producing mucus or phlegms. Okay, often producing mucus or phlegms. So we have that. Two, we have fever, but their fever is quite low grade. Low grade 37.5, 30, 30, 38. Okay, you don't really get 39 or 40. They are around 37.5, 38. Okay, they usually get the low grade fever. Why? They get fever because inflammation. I gave you the 5 signs of inflammation, right? We have warmth, we have redness, we have swelling, we have loss of function, we have pain. So we have warmth, we have redness. Okay, so warmth means fever. You are going to be a bit warm because inflammation is going on. Okay, and then they usually get around 37 to 38. Okay, so that is something that is. And then please take note, their fever is not high. I mean, you don't categorize that high fever. We say it is a low grade fever. Okay, it's a low grade fever. Okay, it's a low grade fever. All right. Then 3, weight loss. So unintentional weight loss and loss of appetite. So when we say unintentional weight loss, what it means is that it is not because the patient wants to lose weight. The patient eats. Okay, the patient eats. The patient does everything to increase their weight, but then they are still not increasing their weight. This is what we mean by unintentional weight loss. Okay, you are eating, you are sleeping well, you are not stressed, you are doing everything to gain weight, but then still you are losing weight. It's a key sign of what? Of TB. Okay, it's a key sign of what? Of TB. So that is something you should know. Okay, and then sometimes they can get loss of appetite. Okay, sometimes they can get loss of appetite. That is something you should. And even if they get a loss of appetite, it will contribute to the weight loss. But what really contributes to the weight loss could be the infection. Okay, yes, when you are getting infected by the bacteria and you are getting inflammatory process going on, when infections are occurring in the body, what happens is that the body already always have their metabolic rate high. You get it? Because they are trying every means to fight the infection. So already metabolic rate is high. And when metabolic rate is high, you use your body's energy. So you get it? So they can get weight loss, okay? Then 4, there can be night sweat, okay? There can be night sweat by way of inflammation of the bacteria spreading, okay? They can get night sweat and they can be recurring. This, they can also get 5 chills, okay? They can also get 5 chills. Then 6, night sweat, okay, same thing. Then 7, chest pain, okay? 7, chest pain, because if you cough, you contract your lungs. You cannot feel the pain on your chest, and then begin to have what? Chest pain. Now, let me tell you something. On the NCLEX, maybe, as I'm saying, maybe after this topic, after the respiratory system, after we are done with the respiratory system, I will try and do oncology and then the lymphatic system, okay? This Hodgkin lymphoma, breast cancers, and the rest. Okay, then you would treat Hodgkin lymphoma. But before you even get there, let me tell you something that when a patient has Hodgkin's lymphoma, cancer of the lymphatic system, lymphoma, cancer of the lymphatic system, they will get everything that is here. The coughing will be present, especially night sweat, chest pain, chills. They get these things. So sometimes on the NCLEX, you can get confused. You can get confused. Please take note. Now, the difference between TB and Hodgkin lymphoma, to help you, I'm giving the difference, is that the diagnostic test is different. Their diagnostic tests are different, okay? So for Hodgkin lymphoma, they will do what you call with Sternberg cells. Okay, they will do what do you call it? They'll do a test for the presence of lymphoma. So they do a biopsy to check the presence of Sternberg cells, and usually they will going to get the presence of Sternberg cells after the biopsy. Okay, but then for TB, you are going to see what? You are going to see things like chest pain or chest X-ray, sputum, and a PPD. So at least if you don't know anything, anytime you see TB, some people they rush. I know. When you are solving questions with students and all those stuff, they make a lot of mistakes because sometimes the people they rush. Once they read the question, they want to conclude. No, please, if you read the question, don't conclude. If you see 9 chills, if you see 9 sweats, weight loss, fever, don't conclude until you see that the patient have a positive chest X-ray and a positive sputum. If you see the presence of Sternberg cells, that is Hodgkin lymphoma. Though they have 9 sweat, they have chills, they have weight loss. Please, is it clear? Am I making sense? Am I making sense?
Yes, please.
Okay.
Yes, you're making sense.
Okay. All right. So that is that for the TB. Okay. So active TB, you are expecting coughing, you are expecting fever, 9 sweat, 9 weight loss, chills, and then chest pain out of the coughing. Now, here is where I want you to pay attention, especially the number 1, the Mantle test. All right. So how do you diagnose TB? How do you diagnose TB? 1, Mantle's tuberculin skin test, the TST. It's a skin test that measures the body exposure to TB. Please, let's first of all establish this fact. This test does not conclude your TB. Please take note. Skin Mantle's test does not conclude that you have TB. It measures body's exposure alone. Are we clear? Okay. Inject. So how do you do it? You inject the PPD. The full meaning of the PPD is the purified protein derivative. Okay, the purified protein derivative, PPD. What do? You inject it into your skin. Okay, intradermal. Let me okay, so when you want to give injection intradermal, what angle should you give it? At what angle? Yes, injection. At what angle? Oh, yes.
15.
According
Sir,
to
15 degrees.
15
okay,
degrees.
15 degrees. Okay, so we should just do it 15 degrees. And then they usually use a small inch syringe. Okay, 15 degrees. So please let's take note. All right. So this test is done intradermal. Okay, it is given to the intradermal. They inject the PPD into your skin, the intradermal layer. Okay, and then you allow the patient for 48 to 72 hours. So sometimes we ask the patient to go and come back. Okay, we ask the patient to go and come back later for the results. Good. So they will inject this purified protein derivative into your intradermis. Okay, good. Now, when they inject it, they will wait for 48 hours, 72 hours. Then you come back for us to read if it is positive for exposure, not positive for TB, positive for exposure to TB alone. Okay, all right. So when you come back, what should we monitor? What are you going to check? One, we are going to check induration, not redness. So sometimes it's because we've injected you. I told you, what is inflammation? When I said inflammation all the time, you hear me say inflammation. What does it mean? Inflammation simply means body's response to any foreign thing at all. So when something cuts you, you feel pain. Do you know why you feel pain? Inflammation is going on. That is why you feel the pain. You don't feel the pain because the knife cut you. No, you feel the pain because the body is trying to sense something foreign. So when you inject the patient body, when you inject, you don't feel pain or redness because something has just injected you. The body will try to respond. What is going on? Under normal circumstances, I shouldn't feel this injecting pain. So once the thing injects you, the body will respond to that injection. Then you begin to see redness. You begin to see swelling and a lot of stuff around the area. So sometimes after they inject the PPD, you will see redness. Please, if you see redness, it doesn't mean that there is exposure. We need induration, not redness. So a 55-year-old man admitted to your ward is being discharged, okay, for TB. Which of the following statements made by the patient indicates correct understanding of the teaching on tuberculin skin test? Then the patient tells you, okay, when I see redness after skin tuberculin test, it means I have exposure to TB. It is wrong. You don't have to see redness. You have to see induration rather, not redness alone or not redness. All right, please, let's pay attention because sometimes they trick you. Okay, they trick you. So it is induration that we need, not redness. Okay, and when you see the induration, it indicates a positive test, meaning that the person has been exposed to the TB. The person has been exposed to the TB. Okay, all right. So normal range is 5 to 15 millimeters. Okay, 5 to 15 millimeters. 5 to 15 millimeters. So when the patient comes and then there's an induration, the induration means a bleb. Let me see. A bleb. When you see a bleb, okay, induration or a bleb is the same thing, okay? Induration or a bleb. So a bleb after TB, okay, after TB. Good. Let me show you how it looks like. Let me show you how it looks like so that when you see it, you'll be able to identify that this is what you're talking about. Good. Let's look at this picture. Please look at this picture. Look at this picture. Let's look at this picture. Can you see this picture, please? Can you see this picture?
Yes, sir.
Have you seen that one of the skin is oh, please let's mute up. Please let's mute up. Oh. Have you seen that one of the skin is just redness? Have you seen just redness? And the other one is induration. Have you seen it? So this is a negative sign. When you see just the redness alone, I was talking about, if you see this alone, this is wrong. This is wrong. This is the correct thing you are expecting. Please, are you following? Okay.
Yes, sir.
So this is what we mean by the induration. The one that is, I said is correct. This one is the induration. What you see, the small bleb over there, not the redness. So if you see just redness alone, it doesn't mean that the patient is have exposure. No. But if you see this boil or bleb over there, it means that the patient have what? Have the induration. Okay, very good. All right. Good. Okay. All right. So that is it. So now when you see that bleb, that swelling over there, what should you know? It should be between 5 to 15 to give you positive. Okay. Between 5 to 15 to give you positive. Now, please take note. There's a hand up. Yes, mommy, mommy or something. Yes.
Hello, sir.
Yeah.
I want to ask, what they used to do the measuring? Is it the tape measure? And also when you
Yeah.
give, and also
Yeah.
when you give this test to the patient, what are the teachings? Are you supposed to tell them with the arm that you used? What are they expect to do before coming within the 72 to 48 hours? Thank you.
Oh, okay. So you don't do it, you don't give them any special, I mean, any special thing. They should just come normal. You just inject. It's just a small injection. Okay, they will just come normal. They will not do anything with the arm. They will not do any special thing to the arm. There's nothing like maybe let me see. There's something like maybe a pre-op something or pre-procedure something. They just come in just like I mean a normal person. Okay, for the test to be done. Then we have a millimeter ruler. Okay, we have a millimeter ruler or a caliper. That is what is being used to measure the millimeters. Okay, we have either a millimeter ruler or a caliper. So they just use that one to just measure the bleb. Okay, all right. So that is that. Okay, are you okay?
Yes, please. So it means that
Mhm.
after the injection, if the patient touch the place, maybe pinch herself where the injection, it will not alter the results.
Oh
Is
no,
that
it won't. Yes,
oh,
Hello, sir.
yes,
Yes, but after the injection, you don't, the patient is not supposed to scratch the place
yes.
so that it doesn't give any false reading. Like
Of course.
normally when they give, as soon as they give the injection, they will use the marker to
Mhm.
circle that spot that they gave the injection. And they will
Yes.
tell you that when you are even bathing, don't use the vigorous scrubbing on your body, on that side. And then you are not supposed to scratch the place. You are not supposed to apply any dress, no any cream or anything on that spot. So that it doesn't give any false positive or false negative reading.
Okay. All right. Thanks for the addition. But then aside these things, you don't have to maybe do any special thing to the hand. Okay. You just have to allow for a good reading. Okay. You don't do any special thing to the hand. You just allow for a good reading. Okay. All right. Good. So that is that. Now we have the 5 millimeter to 10 millimeters by using the caliper or the millimeter ruler to check. Okay. Now one thing you should know is that we have dimensions for each individual that we check. So what I mean by dimension is that if the person we check the TB on, or if the person we want to rule out the TB is an immunocompromised patient, or the patient has just received an organ transplant, for them, the moment we even get 5, it is positive for exposure. Okay, yes, a patient who have HIV/AIDS, a patient who is taking chemotherapy, a patient who has received an organ transplant, the moment we check and it is above 5 or 5, not even above 5, the moment we check and it's 5 and above, please, it is positive for TB exposure. Okay, because already for them, their immune system are compromised, so we don't need 15 to see the exposure because for them the immune system are not strong. So slight exposure, they will begin to have the induration. Okay, or they begin to have the bacteria starting to have effects on the body. So for immunocompromised patients, for organ transplant patients, it should be 5 and above. Then we health workers, nurses, doctors, lab technicians, drug abusers, those who inject themselves with cocaine and the rest, and children who also have immune system not being strong, they should be 10 and above. 10 and above. Now, any ordinary person at all who is not a health worker, who is not immunocompromised, who is not a drug user, for them 15. So if a health worker come and you check and they get 5, it is negative. But if a health worker come and you check and you get even 8, it's negative. A health worker must be 10 and above. If you check and they get 12, 13, means there's an exposure. If any individual at all comes, you check and they get 12, it is wrong, it is negative. Any individual who is not a health worker must get 50 and above for you to get a positive exposure to TB by the skin monkeys test. Hope it is clear. Please, is it clear? Yes. But then a patient with immunocompromise, you don't have to wait to even 10 or even 8. Once they get 5, it is positive exposure for TB. Okay. All right. Now, when they get the TB, when they get the exposure, that alone cannot conclude that the patient have TB. No, you can't conclude on that alone. That means you have been exposed. So what should you do to know that the patient really have the TB? You need further test. You need a chest X-ray. You need a sputum culture. So a chest X-ray will be done to check your lungs to identify interstitial infiltrate. If they see what we call interstitial infiltrate, then it means that you have TB. And then they can also do sputum culture. The sputum culture, we want 3 sputums on 3 different days. So today you do early in the morning, the next day you do, and then the last day you do. So 3 days. So Friday, Saturday, Sunday, Monday, Tuesday, and Wednesday. We take 3 sputum to check. And now for the positive, if we get even 1 positive or even 2 positives, we don't even have to get to 3. Once we get 1 or 2, we can conclude that the patient have TB. Okay, we can conclude and start the treatment that the patient have what? TB. But for negative, you should get all 3 negative. When you check 1 and 1 is negative, you don't stop. Further check again and check again for the 3 of the sputum for all of them to be negative before we can conclude that the patient have what? TB. Now, among all these tests, sputum culture is the gold standard to rule out tuberculosis. Okay, sputum culture is the gold standard to rule out tuberculosis. All right, so please take note. Now, let me ask, should you wash your mouth before taking a sputum? Yes, should you wash your mouth?
Yes.
No,
No, please.
no.
Yes.
No, you don't wash. And rinse with
Oh,
water.
You can
someone.
rinse, but you don't
You
wash.
can rinse, you can wash.
Okay.
Wash and rinse. What's the difference?
should I tell the difference?
Me, I want to know.
When you finish eating, how do you rinse and how do you wash the plate?
I guess.
If I'm asking a question, how do you wash and rinse the plate?
Oh, okay. So the rinse, just water. Wash.
You add soap.
Yeah. All right.
Good. So that's it. So you don't wash, but you can rinse. So rinse, you just use water to clean your mouth. But if you want to wash means that you are now going to add Pepsodent. You are going to add a lot of what? Chemicals. So all these chemicals, like from the Pepsodent, can affect the results. So you just need a clean water to just rinse your mouth. You don't wash. Please take note. You don't wash. You don't wash, okay? And then another thing you know for sputum culture is that never touch the inside of the container. Never touch the inside of the container. You give a false positive. Okay, never touch the inside of the container. It is not done. So please take note. You don't wash your mouth. You can just rinse your mouth. Okay, you can just rinse your mouth before the procedure, and then you cough forcefully. Because we need sputum. We need you to bring the everything in your in your inside. Okay. We want you to bring the ahro for us to get the right what bacteria. Okay, so you cough, and you bring the sputum out. Then it is done early in the morning, right after waking up. Because after waking up, a lot of sputum has collected. Okay, you during the day, people spit, people cough, people sneeze on the day. So during the day, you will not get a proper. But if you sleep and you wake up, all of them are collected in your throat. So you can now cough forcefully and bring the correct sample that we need for the test. So it is done early in the morning, one. Okay, sputum done early in the morning, right after waking up. Two, you must cough to bring the sputum out. Three, don't wash your mouth. You have to rinse. Four, never touch the inside of the container, okay, for the procedure. All right, good. Then the point 2 on my screen, the other test we can do is the interferon gamma release assays, the IGRA, the interferon gamma release assay. So blood test that measure the minimum what? That measures the minimum, measures the immune response to TB. Sorry, it measures your immune response to TB, okay? It measures the immune response to TB. And it includes the quantiferon TB gold test. Mommy, yes.
Thank you, sir. What of the clients that has an NGT bond? How do you go about the sputum?
Okay, I'll come to that.
Okay,
Okay,
thank you.
okay. All right. Then we have the interferon gamma release assays. Okay, the interferon gamma release assay. So this one is a blood test that measure the immune response to TB. Okay, measures the immune response to TB. And then we have two forms. We have the what do you call it? We have the quantiferon TB gold test and then the T-spot. You know, these ones, they are not common, okay? They are not common. They are not common, okay? So that these ones, they don't really something to bother yourself about. And then this one, patient does not have to return. What does it mean? It means that this patient, what you should just know is that they can have the results right away, okay? Right away. So they don't have to return the next day. You know, for the skin monsoon test, they have to return in the next 48 hours or 72 hours for us to check the results. But then for this quantiferon and then T-spot, it's just a blood sample test that we did, and then the patient who can get a result the same. They don't have to go back or return for the results to be what, to be checked. Okay. All right. So that is that. So these are diagnostic investigations. Okay. These are diagnostic investigations. All right. Good. For a patient who has TB and want to diagnose. So, madam, you asked the question that for a patient with TB, NG tube, who cannot really cough, I mean, they usually do what you call oropharyngeal suctioning or gastric aspiration, okay, for us to check, you get man, to get a sputum, okay. So you can do what you call the oropharyngeal or nasopharyngeal suctioning to get the sputum, and then we can use that one to test for the procedure, okay. All right, so that is that. Next interventions for TB. Next interventions. One, collect sputum for cultures at least 3 to 4 weeks. So this is when you started the treatment. Okay, this is after you've started the treatment, the medications, which we'll talk about it very soon. You started giving the medications to the patient, and then we have to check the patient to see if the medication is working or not. So you give yourself up to like a month, 4 weeks. Then you keep on checking the sputum at least every 3 to 4 weeks. After 3 to 4 weeks, not every. After the first 3 weeks to 4 weeks, you check the sputum and see if it is correct. And then you need 3 sputum. You need 3 sputum on 3 different days. Okay, you need 3 sputum on 3 different days, and all of them must be negative. If you have 1 negative and 2 positive, the condition or the medication should continue. Okay, the medication should continue. So you need 3 negatives of the sputum to conclude that the patient is now free from TB and not infectious. Okay, all right. 2, you give them high carbohydrates, high protein, and with small frequent meals. Okay, because when a patient have TB, they can have issues with their airway, they can have difficulty breathing, and then when patient have difficulty breathing, usually they have difficulty eating as well because they don't have the energy to eat for long. So you give them small frequent meals, but then the small frequent meals you're giving them should be high in carbohydrates and high in protein. Then 3, they may need directly observed therapy, into bracket DOT. Why? Let me ask why. Public health nurses over here. Why do they need DOT? Directly observed therapy. Why? Anyone who has worked at a public health team before? Yes. Why?
Hello, sir.
Yes.
Because the treatment is a long-term treatment, that it takes a long time for them to be on the drugs. And again, the side effects of the medications, you need to monitor the patients whilst patient is on it. And then if the patient is developing any side effects, you now be able to intervene appropriately. So you need to be observing them how they are taking it for compliance and then side effects as well.
Okay, all right. So that is it. Okay, because they can take the medication for like 6 months, sometimes 9 months. So imagine taking medication for 9 months. Oh, so sometimes they tend not to take it. So they need directly observe. What it means is that you must watch them place the medication in their mouth. Okay, you must watch them. So that is why in some hospitals, the big hospitals, they have TB units. For them, the nurses give the medication to the patient themselves. Okay, they give the medication to the patient themselves, so that they can directly observe them taking the medications. Other than that, those who stay at home and take it, Charlie, if you don't observe them, they will not take the medications. Okay, so that is that. So they need a directly observed therapy. Then you isolate patients and restrict visitors, because the condition is contracted through inhaling the bacteria. So you need to isolate, you need to restrict visitors. Okay, all right. Then you have to test family and close contact by reason that they might have contracted the disease. Okay, so you have to what? You have to test family members and close contact. Okay, as well. Then you educate the patient to cough or sneeze in a paper towel and flush right after it, or they use an airtight bag. So a patient might be on the ward, okay, and then they want to cough, and they might either use an airtight bag, they cough into the bag and dispose it off, or they sneeze and cough into a paper towel and then flush at the WC. Okay, flush at the WC, or they use an airtight bag so that it doesn't allow the air to blow the bacteria outside. Okay. Then lastly, non-hormonal contraception, especially when taking rifampin. We will get there very soon, so I'll not talk much about this one. Okay. All right. So that is something that you should know. Okay. That is something that you should know for next interventions when I'm talking about TB. Okay. Sputum after 3 to 4 weeks. Okay. High carbohydrates. They may need a directly observed therapy as well as the patient, and then it takes family contact. Then what precautions should you keep? What infection prevention precaution should you take? Airborne precautions, right? Yes, airborne, because tuberculosis is transmitted through airborne. So airborne, you need negative pressure room with doors closed. Okay, negative pressure rooms with doors closed. Okay, negative pressure rooms with doors closed. Then you need an N95 mask. The N95 mask, between the patient and the nurse, who wears the N95 mask? Yes.
The nurse.
Okay. So please, the nurse who is the nurse. So the patient can be on a surgical mask, but you, the nurse, must be on an N95 mask. Okay. Oh, it is even on my screen. Surgical mask for patients if transported outside the room. Okay. So for them, they can use surgical masks, but you, the nurse, must be in an N95 mask. All right. Perfect. Good. Now, treatment. Okay, treatment. The medications. Another NCLEX interest. Please, let's pay attention. Okay, let's pay attention. Sorry. Another NCLEX interest. So let's pay attention. So a combination of drugs is used to treat TB, typically for 6 to 12 months. Okay, for 6 to 12 months. Okay, for 6 to 12 months. For 6 to 12 months. So the drugs, anytime we talk about TB drugs, remember the word peri. Okay, remember the word peri. Okay, umbilicus, whatever peri. Okay, all right. So just remember the word what? Peri, P-E-R-I. Okay, P-E-R-I. What peri is a word which stands for around, surround. Okay, about, near. So, but just use the word surround, around, about. Why? Because we need drugs that can surround the bacteria and prevent them from multiplying. That is why the word peri. Okay, that is why the word peri. So just remember the word what? Peri for tuberculosis drugs. So peri, around, they surround and colonize the bacteria from multiplying, from spreading, okay? And then it kills it. So that is that for peri. Okay, so now, P in the peri stands for pyrazinamide. Pyrazinamide, okay? Pyrazinamide. What does it do? It kills the bacteria up front. It just kills the bacteria. Now, what should you do about, or what should you know for your NCLEX about this pyrazinamide? One, it causes hepatotoxicity and increases uric acid levels. So, a 55-year-old man was admitted to your ward with liver cirrhosis. With liver cirrhosis. The doctor prescribed the following drug. Which of the following drugs should you clarify? A, pyrazinamide. Correct answer. You should clarify pyrazinamide because already it causes hepatotoxicity and patients have liver cirrhosis. You don't have to take this drug in liver cirrhosis. No. Don't combine this drug with paracetamol. You will kill the liver because also paracetamol also causes hepatotoxicity. Please, are we here? So every drug you know that causes hepatotoxicity, don't combine it with pyrazinamide. No, it's a no-go area. And don't give this drug in liver cirrhosis. You should clarify this drug in liver cirrhosis. Okay, so it causes hepatotoxicity and increase uric acid level. When you hear uric acid level, what condition comes to mind? Basic. Yes, what condition?
Gout.
Gout. Yes, gout. Gout. So don't also take this medicine in gout. Because already in gout, patients have high uric acid level, and you are going to take this drug, you worsen the case. Okay. So that is something you should know. Then you should administer with food. You should administer with food. Give it with food. So please know this for your NCLEX. For TB drugs, pyrazinamide causes hepatotoxicity and increase uric acid levels. All right. Next drug, ethambutol. So the word peri. Next drug, ethambutol. Prevent bacteria from reproducing, from multiplying. I told you that sometimes when the bacteria, you inhale it and then they begin to colonize your airway, the inflammatory mediators, the immune begin to trigger, they begin to multiply. But this drug prevents them from multiplying, from reproducing. So the ethambutol prevents the bacteria from reproducing. What should you know for this drug? One, they causes optic neuritis, the inflammations of your nerves and neurons around the eye, your optic nerves. So they can cause blindness. So always you have to do regular eye checks because it can damage the optic nerve. Okay, the ethambutol can damage your optic nerve. So you must always do what? Do what? Eye checks. Then it can cause decreased visual acuity. So do you think you should take this drug in patients who have glaucoma, who have issues with the eye? No. Okay. Because already this drug can further even inflame your nerves. Okay. So ethambutol, what should you do? Check the eye often because it decreases visual acuity and causes optic neuritis. Next drug, rifampin. Rifampin. What does it do? It kills the bacteria. So what should you know for rifampin? One, causes reddish orange discoloration of body fluid. So your sweat, your urine, your saliva begins to turn reddish orange when you take this rifampin. When you take this rifampin, please take note. When you take rifampin, it kills your bacteria, but then it causes reddish orange discoloration. Your sweat, your urine, your saliva begins to turn. Don't report this. It is normal. It is expected. Don't go and call the doctor because of this. No. Then you don't have to wear your contact lenses because otherwise it will stain the lens. So need not to wear contact lenses. You don't have to wear contact lenses in rifampin or when you're taking rifampin. Then lastly, they decrease the effect of hormonal birth control. They decrease the effect of hormonal birth control. Can someone give an example of hormonal birth control?
Depo.
What?
Depo injection.
Okay. Which again? What again? What again?
The
Okay.
implano.
So we have a lot, right? Yes. But we have non-hormonal ones. We have what? We have the copper IUDs and then the rest. Okay. So what happens is that if you want to stop pregnancy, please follow. If you want to stop pregnancy, and then you are taking a hormonal birth control whilst taking rifampin, please, when you better know, now on you. By the time you realize you are pregnant, because this rifampin stops any hormonal birth control. It is better to use the IUD. When you really want to prevent pregnancy whilst taking rifampin, then use IUD. If you're going to use the hormonal ones, that we know, the drugs that we know, it will not cause any effect because this rifampin decreases the effect of hormonal birth control. So it doesn't allow it to work effectively to prevent the pregnancy. Okay, so please take note. All right, then the last drug we should know for TB is isoniazid. It also kills the bacteria. What should you know? It also causes hepatotoxicity. So therefore, avoid hepatotoxic agents. Example, paracetamol or acetaminophen. Okay, I told you already. So don't take paracetamol or acetaminophen with what? Isoniazid. 2, it causes peripheral neuropathy. It can damage your peripheral nerves. Okay, it can damage your peripheral nerves. So patient can start feeling paresthesia, numbness around their limbs, around their legs. So to prevent the peripheral neuropathy, take pyridoxine or vitamin B6 when you are taking isoniazid. Please, are you following? So a patient was admitted to your ward with tuberculosis. Patient was prescribed isoniazid and therefore stands a higher chance of getting peripheral neuropathy. Which of the following drugs or medications should you prescribe to prevent the peripheral neuropathy? A, vitamin B6, B, vitamin B3, C, vitamin B12, D, vitamin B1. Yes, what's the answer? Vitamin B6, right? All right. So sometimes they will not bring vitamin B6, they will bring pyridoxine. Okay, pyridoxine. So please follow pyridoxine. Okay, pyridoxine. All right. Then lastly, you have to avoid aluminum containing antacids within 1 hour after taking this drug because they can have a drug to drug interaction. Okay, they can have drug to drug interaction. Okay, so always avoid aluminum antacids. Okay, always avoid aluminum antacids when you are taking this isoniazid. All right, so that is that for the drugs. Remember Perry. All right, complications of TB. Complications of TB. There can be drug resistance. So TB bacteria can develop resistance to antibiotics. Okay, sometimes because there's infections going on and all this stuff, they can begin to develop, and the drug, you see, they take the drug for long. So they can begin to develop some drug resistance for antibiotics and the drug they take for the management. Then 2, treatment failure. Treatment may not be effective, especially if not completed as prescribed. Okay, because they are taking the drug for 12 months, 6 months, 9 months. So sometimes some people they will stop along the line, and then this can cause treatment failure. Then lastly, transmission. Untreated TB can spread to others. Okay, untreated TB can spread to others. All right, so that is that for tuberculosis. Nothing special about TB. You know TB, but for TB, for your NCLEX, just know some key diagnostic investigations. Just know the drugs, know your airborne precautions, and probably some signs and symptoms, and you're good to go for your NCLEX. Okay, for TB. All right. Any question? Any question on TB? Any question? Any question on TB? All right. I think there's no question, right? Good. So I'm watching. Yes.
Sir, please, I want to ask if TB has anything in link with lung cancer.
You said what?
Please,
Can you?
I want to know if it has any link to do with lung cancer?
TB, like
Yes, please.
maybe you can TB cause lung cancer or something like that.
Yeah, or can predispose one to lung cancer,
Oh
or it's
yeah,
not
if
possible.
oh yeah, it's possible. If predisposed or risk factor, it's possible because there's going to be inflammation, there's going to be lung scarring, okay, like lung damage when you have TB. So obviously it can be a risk factor because chronic inflammation can lead to scarring and fibrosis, okay, which can predispose you to getting lung cancer. Okay. Yeah, so it is possible. It is possible.
Thank you.
You're welcome. Okay.
Hello, sir.
Yeah, Mr. Musa.
So good afternoon.
Afternoon.
Sir, with regards to the TV drugs,
Mm-hmm.
I saw one of this thing under boot camp. I was
Okay.
answering. I log in to their space and they give me 100 free to answer.
Okay.
So during I saw something instead of the reform person, the drug was reform pitting.
Yeah, it's the same.
And after that, in their explanation, they said they've changed some of the drugs, that they've removed ethambutol out from TB treatment and put moxifloxacin. So instead of taking the drugs from 6 to 12 months, that they are now treating it 4 to 6 months.
Yeah. I get you. I get you.
Hmm.
Yeah, that treatment is there. We have that one. It is called the shorter 4 month regimen for TB. Okay. The
Okay, so
shorter 4 month regimen for TB. Okay,
oh,
whereby they completely omit ethambutol and they do rifampicin, paracetamide, and moxifloxacin. Let me type in the chat
oh,
box. And then that one, moxifloxacin, moxifloxacin. But then what I will tell you about this
okay, so
is that what I'll tell you about it is that see, ethambutol has not universally been removed from TB management. It has not
okay, so
universally been removed. Okay, though
okay,
at some point they can do that 4 month management whereby they take off ethambutol and add this moxifloxacin. Okay, but then please
okay,
take note, universally ethambutol has not been removed because I don't even think we have the moxifloxacin in Ghana here. I don't know. Okay, so it is not universal. Okay, and then that drug just came into the scene. So for NCLEX purposes and for exam sake, you just stick to the ones I give out. Okay. All right.
okay, sir. Okay, thank you, sir.
All right. You're welcome. All right. But we can add it to our notes anyway. The moxifloxacin, we can add it to our notes anyway. All right. Okay. All right. I think there are no more questions. Mommy, we are here today. You have been asking plenty questions today. So we are here today. Yes, read the questions. Where is mommy? Sister mommy. And she's not here. Anyway, who will be a reader for today? Who will be a reader for today? Madam
The
Bennett.
right
Okay.
forearm, the right forearm of a client has the right forearm of a client who had a purified protein derivative PPD test for tuberculosis is reddened and raised about 3 millimeters where the test was given. This PPD will be read as having which of the following results? A, indeterminate. B, needs to be redone. C, negative. D is positive.
Okay, what is the answer? Yeah, what's the answer? This one we are not answering crowd. Those speaking C,
C.
why C? Why C? Why C?
The values is between 5 to 15.
Okay, all right. And then you're even seeing redness, right? All right, so this test will be classified as negative. A 5 millimeters raised area will be positive result if the client has HIV or had close contact with someone diagnosed with TB. Indeterminate isn't a term used to describe results of a PD test. If the PPD is reddened and raised 10 or more, it is considered Mr. Wise positive according to CDC. Mr. Wise. Mr. Wise, raise your hand.
Yeah, but
Yeah.
I just realized the question giving, I didn't actually understand the part where the patient wasn't clear whether they had HIV or they belong to the category of immunocompromised patients or normal staff. So in a case like that, how do we generalize it?
Yes. So we all know that the general diagnostic test for PPD is 5 to 15. So if they don't give you, just use the 5 to 15 without the HIV or healthcare provider or whatever. So if it is 5 or 10, for example, this question was 10 millimeters. This one will be positive because we have a 10 millimeters raised, okay, which means there's an induration. Though they didn't classify it. So this falls within the 5 to 15. It is 10. It falls within the 5 to 15, so it gives it positive. So anything less than the 5 doesn't give it positive. Okay, is it clear?
Yes, it's clear now. Thank you.
Okay, all right. Next question, Madam Bennett.
A client has active TB. Which of the following symptoms will he exhibit? A, chest and lower back pain. B, chills, fever, night sweat, and hemoptysis. C, fever of more than 104 degrees Fahrenheit and nausea. D, headache and photophobia.
Yes. B, right?
The B.
I'll picking B. All right. No time to waste. This one there, I told you, no time to waste. Okay. All right. So next question. Yes.
Which of the following diagnostic tests is definitive for TB? A, a chest X-ray. B, a Montos test. C, sputum culture. D, tuberculin test.
And so C, right?
Yes.
I said this. Okay, I said this already. So C. Okay. All right.
A client with a positive Monto test results will be sent for a chest X-ray. For which of the following reasons is this done? A, to confirm the diagnosis. B, to determine if a repeat skin test is needed. C, to determine the extent of the lesions. D, to determine if this is a primary or secondary infection.
Okay, so relax. This question, you don't relax, you get it wrong. Yes, what's the answer? Is it to confirm the diagnosis? Is it to determine the extent of the lesion? You are all picking C. Okay, but if we need something to confirm the diagnosis, what do we do?
Okay.
It's sputum, right?
Mm-hmm.
So I think the rationale is not here. Maybe it will be on the next slide. Anyway, let's read this. Let's read this question. Maybe the rationale will be on the next slide.
Okay. A client with a positive skin test for TB isn't showing signs of active disease. To help prevent the development of active TB, the client should be treated with isoniazid, 300 milligram daily for how long? A, 10 to 14 days. B, 2 to 4 weeks. C, 3 to 6 months. D, 9 to 12 months.
Okay, yes. Yes. Let's try. I know this one there is old, but let's try. Just guess. Imagine you get this question in English. You don't have to sit down idle. You have to guess. Okay, 9 to 12
C.
months. C. The answer is D, 9 to 12 months. Okay. So because of the increased incidence of the resistant strain of TB, the disease must be treated up to 24 months in some cases, but treatment, typically lasts 9 to 12 months. So isoniazid is the most common medication used for treatment of TB, but other antibiotics are added to the regimen to obtain the best result. So you treat it with 9 to 12 months, okay? 9 to 12 months. All right. So the answer was C. This question, the answer was C, not A. If you need something to confirm the diagnosis, I told you this what it is sputum culture. So here we do the X-ray to see the extent of the lesion. So because of the so if the lesions are large enough, the chest X-ray will show their presence in the lungs. Sputum culture confirms the diagnosis. Again, sputum culture confirms, not X-ray. Okay, not really X-ray, but though you still need an X-ray and a sputum culture, but most at times sputum culture is definite, right? Good. There can be false positives and false negative skin tests. A chest X-ray can't determine if there's a primary or secondary infection, so you need a sputum, okay, for maximum diagnosis. All right, so that brings us to the end of TB. Then we shall begin with pneumonia. Any question? Once and for all.
Can I please see the last question, the isoniazid one, please?
This one?
Yes, please.
Are you okay?
All right, thank you. Yes, sir.
You're welcome. All right, so that is it. So any question? Any question? Any question? We are beginning with pneumonia, okay? Okay, no question. So let's start with pneumonia. Please, do you have any slides on abdominal TB? No, not yet. Abdominal TB, well, maybe you consider that one under infectious diseases. You know, this one we are treating respiratory system. We are trying to do the NCLEX review of the respiratory system. Okay, so this one, TB, is under infectious disease, not under respiratory system, but because it is quite common on the NCLEX and then it has something to do with your lungs, I chipped that one in. So we treated the one that affected the lungs alone. Okay, maybe some other time when we are treating the infectious disease, we do the one with the abdomen and the kidneys and then the spines and the rest. Okay, all right, so that is that. Okay, all right. So pneumonia is another simple and straightforward topic. Okay, nothing special about it. Okay, but it's becoming common on the NCLEX. I mean, so we should know pneumonia. Okay, so what is pneumonia? Pneumonia is an infection of the lungs that can be caused by bacteria, viruses, or fungi, resulting in impaired gaseous exchange due to increased secretion. So this one, I will borrow idea from chronic bronchitis under COPD. Okay, under COPD. Okay, so here too, there's an inflammation of the lung. So here, the inflammation is typically in your lungs, caused by either bacteria, either viruses or fungi, and which result in what? Impaired gaseous exchange due to increased secretion. So pneumonia, see, microorganisms find its way in the upper airway. Okay, microorganisms find its way or invade your upper airway. Okay, so maybe by through coughing or inhaling or something like that. Now, when you inhale the bacteria, we have a lot of bacteria that causes the pneumonia. Okay, they are here. We have the pneumocystis, aerobicin pneumonia. We have the Streptococcus pneumoniae. We have the Haemophilus influenza. There are a lot. All these things can cause pneumonia. Okay, so now when you inhale this bacteria or virus or fungi, they enter your airway and move straight to your lower respiratory tract, that is your lungs. Now, when they get there, they cause pulmonary capillary or dilations. They begin to dilate your capillaries, your blood vessels, and other things in your lungs. Now, one day when dilation happens, what will happen is that inflammation is taking place. So dilation, increase in permeability. what we realize is that there will be what? Fluid leakage leading to exudate formation in your alveoli. So get the pathophysiology. You inhale the bacteria or the virus or the fungi, then it goes down to your lower tract infection. When they get to lower tract infection, they begin to cause dilations in your airway. The dilation will cause increase in permeability, therefore leading to fluid leakage. Once there's fluid leakage, then it will lead to what? Exudate formation. Exudate means sputum. Exudate means what? Fluid. Then the lungs becomes very, very heavy, containing protein-rich fluids, and they multiply what? The bacteria. Because now they contain protein-rich fluids. That will help the bacteria to multiply. The alveoli become now packed with a lot of red blood cells, a lot of neutrophils, disinflammatory mediators, okay, and all this stuff. Then it begins to what? Restrict what? Gaseous exchange, because it becomes heavy, filled with bacteria, multiply, exudate. This begin to what? Begin to impair gaseous what? Gaseous exchange. Okay, then it begins to what? Form cellular debris, fibrin, fluid become reabsorbed, and all these things. Okay, then this is cause what? We say there's pneumonia. So that is the pathophysiology of pneumonia. I know pathophysiology is not really needed on the anklets. You don't need pathophysiology for your anklets, but sometimes it is good that we treat or we just brush through it. Okay, so you inhale bacteria, viruses, or fungi. When you inhale them, they begin to cause what? Capillary dilation. They dilate your blood vessels around your airway. Once they dilate your blood vessels around your airway, they begin to form what? Exudates, or fluid begins to leak out. Once there's fluid leak out, the alveoli, the lungs becomes heavy. It begins to contain protein-rich fluids that multiply the proteins and the bacteria. Then they begin to interfere with what? With gaseous exchange. They will say you have what? You have TB. So that is that for TB. Okay. All right. So types of pneumonia. Hey, I said TB. Types of pneumonia. Okay. Types of pneumonia. Okay. Types of pneumonia. We have one. Community acquired pneumonia, CAP. This one occurs outside of hospital and healthcare facilities. Okay. It occurs outside of the hospital and healthcare facilities. Okay. It occurs outside of the hospital and then healthcare facility. That is community acquired. Then we have two. Hospital acquired pneumonia occurs in the hospital and healthcare facilities. Then three, we have aspiration pneumonia occurs when food, liquids, or other substances are inhaled into the lungs. Very, very common. Okay, especially patients with stroke, patients on ventilators. Okay, if care is not taken, they can get aspiration pneumonia. When food substances, when liquid are inhaled into your lungs, they can get the lungs infected and they can get aspiration pneumonia. Then lastly, we have ventilator associated pneumonia. Okay, ventilator associated pneumonia, VAP. Okay, ventilator associated pneumonia. So these are the types of what? Of pneumonia. All right. So causes and risk factors. I told you earlier on that pneumonia is caused by bacteria, it's caused by viruses, it's caused by what? Viruses, bacteria, and fungi. So some bacteria that can cause is Streptococcus pneumoniae. Okay, Streptococcus pneumoniae can cause it. We have Haemophilus influenza. We have Klebsiella pneumoniae. They are all bacteria that can cause what? Can cause pneumonia. Then two, we have viruses. We have influenza. We have respiratory syncytial virus. We will talk about this condition. I think that is our last topic under the respiratory system. Okay, respiratory syncytial virus. We also have adenovirus. All these things can cause pneumonia. Adenovirus. Then three, we have fungi. We have Pneumocystis aerovisi pneumonia. Okay, the name is very, very, very heavy. Pneumocystis aerovisi pneumonia. Okay, all these things are bacteria that can cause what? Pneumonia. Then three or four, sorry, we have pre-existing lung infection. For example, bronchitis in COPD. So you have COPD, we have bronchitis. There's inflammations going on in your airway. This bacteria or this inflammation can extend to the lung. Once it's extended to the alveoli and all these things, it begins to cause issues with what? With your lungs, you can get pneumonia. Okay. Then one thing is that you see, when you get infections or inflammations, the integrity of your lungs are affected. You know how strong the lungs were or how intact your lungs were are not like the same. So if care is not taken and you begin to inhale any other thing else in your environment, they can begin to cause a lot of infections in the airway. Okay, so pre-existing lung infection can cause. Then 5, immunocompromised patient. Of course, we all know that the immune system is designed by God to help you fight infections, help you fight bacteria. So if you are immunocompromised and you inhale this Streptococcus pneumoniae, how can you fight it? Okay, so you are that type that you have immunocompromised Streptococcus pneumoniae. If you inhale this bacteria, because your immune system is weak, it is low, they can't fight this bacteria. They will colonize the airway and begin to cause pneumonia. 6, patients on mechanical ventilators. Yes, sometimes they stay on the ventilator for long. Sometimes they can aspirate because when you are giving them, when you have the ventilator on, sometimes the way they eat, they lie down to eat, and a lot of stuff. Okay, so they can get a ventilator associated with pneumonia. 7, difficulty swallowing. Patient with dysphagia, patient with a stroke, and they have difficulty swallowing. All these patients, they are unconscious patients. Unconscious patients, they can begin to have high risk for pneumonia. 8, advanced age. Advanced age. When you are aging, the aged, of course, you are growing. It is natural. How the lungs used to function will be reduced. How the immune system protects you will be reduced because you are aging, you are growing old. All these things can put you at risk for pneumonia. Then lastly, smoking. We all know how smoking can endanger your body. Smoking introduces toxins to the airway. Okay, when you are smoking, you are inhaling smoke all the time. They are introducing toxins, okay, to the airway, which can also have an effect on your lungs. So that is the risk factors for pneumonia. All right. So the symptoms. The symptoms of pneumonia. So coughing. A persistent cough often producing mucus and phlegms. Why do we have coughing in pneumonia? Yeah, someone should help me. Why coughing pneumonia?
So let me try.
Okay, try.
I think because there's a foreign substance in the respiratory tract, the body is trying to help itself by bringing it out through a cough.
Okay, compensating, right? So that is it. So that is that. 2, we have fever. Here we have high fever. We have high fever. Okay, we have high fever. Unlike TB, we have low grade fever. But here we have high fever. So please take note. They can get 40 degrees. Okay, they can get chills and sweating as well. So if you want to distinguish between pneumonia and TB, know that in pneumonia they have high fever, whereas in TB they have what? They have low fever, low grade fever. Okay, so please take note of that. All right. 3, shortness of breath, difficulty breathing, or feeling winded, even when sitting still, because the lungs are inflamed. Your lungs are used for breathing, and if they are inflamed, what is going to happen? There's mucus. The lungs are inflamed. There's mucus in the airway. There's fluid in the airway. Air does not pass. How will the air diffuse into your body for oxygen? Therefore, they can have difficulty breathing. Okay. 4, chest pain, sharp chest pain that worsens with deep breathing and then coughing. Of course, because the airways are blocked with mucus, you've inhaled a bacteria called Streptococcus pneumoniae. They are causing dilations in the airway, causing fluid to fill the lungs and the alveoli. Therefore, air does not pass and come probably because the fluid. What do you think is going to happen? You cough consistently. This will cause pain in your chest because consistently you are coughing. And even if you deep breathe, because you are trying to force the air through the airway and it's meeting some resistance, it's going to cause what? Pain. Okay. All right. Then 5, increase respiratory rate. Increase respiratory rate. Of course, you have to compensate because the body is not getting the oxygen. The body will be like, hey, Charlie, see. I'm not breathing this way. I usually have to breathe normally, but I feel something wrong in my chest. I have to do something because the kidney needs oxygen, the brain needs oxygen, the liver needs oxygen. If I'm getting pneumonia, how the oxygen get to the brain, the liver, the kidney? Let me force it to compensate for these organs that they don't die. Therefore, they get increased respiratory rate out of the compensation. All right, 6, confusion in older adults. Example, of course, I just spoke about it. If you have low oxygen, how will the oxygen get to the brain? And then usually in adults, if you have low oxygen getting to the brain, they tend to get confused. Okay, they get delirium and the rest. Okay, they get deliriums and then what have you. So please take note. Confusion common in older adults with pneumonia because the oxygen is not getting to the brain. Okay, so that is something you should know. 7, irritability and poor appetite in children. These are common signs and symptoms that you should know in children when they are sick. They become sensitive. You touch them when they are crying. Okay, and then they have poor appetite, especially when it is in children. Okay, Then 8, increased vocal tactile tremors. Who can explain why there's increased vocal or tactile tremors? Yes, who can explain? Yesterday I gave an explanation why there is a decreased vocal tactile tremors in yesterday's condition. Why increase today? Yes, why? Someone should help us. Someone should answer it and give the person Halewa. Oh. Okay, what is phlegmatos? What is phlegmatos? What is phlegmatos?
Vibration.
Vibration. Good. What is tactile?
Touch.
Okay. Touch. Okay. Mr. Wise has raised the hand, so let me allow Mr. Wise to talk.
So basically what that means is that because there is consolidation or there is exudate forming the alveoli, it makes the alveoli to be filled. So when you touch the surface of the back or when you try to touch the back, or the vibrations you get would be increased because the sound is passing through fluids.
Okay. All right. So phlegmatos means vibration, tactile means touch, vocal means talking. And yesterday I gave you an example that when you touch your back and then you speak, there's some vibration at your back. Why? Because the vibration when you speak or the sound creates some vibration and it's able to pass through your lungs very well to your back. Okay, because sound travel best. Okay, sound, it travel best in dense areas or dense environment. So areas whereby there's too much fluid density, dense, it will travel very, very well. But then if there's air, sound does not travel well in air. That is why in pneumothorax there's air in the pleural space, so the sound does not travel to your back. So there's a decreased tactile vocal phlegmatos in pneumothorax because the sound is not traveling well in air. But here in pneumonia, you have exudate, you have fluid in your alveoli, water, dense area. So now sound can travel well to your back. Hence, we have an increased vocal tactile phlegmatos. Okay, it's as simple as that. Okay, it's as simple as that. All right, so that is that for pneumonia. Okay, that is that for pneumonia. Okay, all right. See, sometimes when I'm trying to explain these things, you should pay attention. Honestly, the reason is that sometimes when you go for the NCLEX, or if you start using kill banks, especially those who start using the kill banks, and then you meet questions like pneumonia, asthma, then they will bring it. They will line the symptoms down. They will line the symptoms there. So they will bring fever. They will bring increased tactile vocal phlegmatos. They will bring tachycardia. They will bring confusion, shortness of breath. Then they will give conditions like TB, pneumothorax, and pneumonia. Then they will be asking you, pick the signs and symptoms and correspond it with their condition. So if you don't know some of these increased tactile, they can confuse you because they will put it there and they are expecting you to pick it for pneumonia. So if you don't know and you pick it for pneumothorax, you get it wrong. Okay, so please, the signs and symptoms, they are important. Okay, they are very, very important. You should know which one is increased, which one is low. For example, in pneumonia, I told you that they have high fever, but in TB, it is low grade fever. Okay, so if they line it up, for example, they bring low grade fever. No, low grade fever is for TB. High fever is for what? It's for pneumonia. So please, let's take note of them all. It is not everything that you can learn at once, or it's not everything that you can learn whilst you are studying. So when you are speaking or when you are teaching, you pick it and then you move along with it. All right. So diagnostic investigation. How can you diagnose pneumonia? One, chest X-ray. Okay, chest X-ray. They will show infiltrate or consolidations. Okay, you realize that the chest, there are some infiltrate, like something has been filled in the your lungs. Okay. So when you take an X-ray and you show infiltrations on your lungs, this means that there's what? There's chest X-ray. Okay, there's chest X-ray. Two, blood cultures. Blood cultures. So you can do full blood count. You can do culture sensitivity test. Okay, I mean sputum culture and blood, even blood CS. Yeah, you can do blood CS. Okay, to rule out. And then when you do blood CS, you see the causative organism. Okay, blood CS is done to rule out the causative organism. Okay, and you can do full blood count. So full blood count or CBC. CBC means complete blood count. Full blood count is FBC, right? Yeah. So when you do all these things, it will let you know the amount of white blood cell we have. If I may ask, what is the normal white blood cell for a normal patient? Normal white blood cell for a normal patient. Yes. Oh, 4,500 to 11,000. Okay. 4,500 to 11,000 normal white blood cell. So in a patient with pneumonia, we have high fever, high infection. So the BBC will go up, will go above 11,000. They can get 11,500. Okay, this is a sign of what? Of infection. All right. Three, sputum culture. A sputum culture can help identify the causative organism. And lastly, leukocytosis on CBC. So when you do your leukocyte count, it will be very, very high, which means that there's an infection. Okay. So that is that. So these are how you can diagnose pneumonia. Please note showing infiltrate on chest X-ray, because sometimes on the NCLEX, when they bring the condition in case studies, they will attach the diagnostic test. So you have to rule out infiltrate to prove that the patient is having what? Is having pneumonia, or you have to see infiltrate. So please take note. All right. The next interventions. How can you intervene when a patient have pneumonia? One, monitor pulse oximetry reading and titrate oxygen as needed. So, I mean, you put an SpO2 machine or pulse oximeter on the patient's hand to check the patient's SpO2 levels and everything that the patient will present with. I mean, the things that we know. Okay, so SpO2 should be 95 to 100 for normal person. So you should be checking all the time, and then you titrate your oxygen if needed or as needed. So if the SpO2 is going down, you now increase what? You now increase the oxygen. Two, monitor respiratory status. Okay, monitor the patient's respiratory efforts and then the rate at which they are breathing. So respiratory efforts and then the rate. To monitor respiratory status. Do they have a high respiratory rate? Are they breathing with accessory muscles? Are they suffering to breathe? So you must check all these things. Okay. Next point, promote hydration to liquefy secretions. I told you that there's going to be exudate in your alveoli, in your airway. There's going to be exudate. So one way you can break the exudate and the sputum out is to increase water intake. Because when you increase water intake, it is going to thin the secretions and you are able to what? Cough them up easily. To promote hydration to liquefy secretions. Next point, teach the use of incentive spirometer. At least 10 times every hour if awake. Okay, what is the function of incidence spirometer? I told you under asthma. What is the function of incidence spirometer? Yes. It measures what whilst you do what? Let me give you the clue. It measures the amount of what whilst you do what?
The amount of air what we inhale.
Whilst you
Inhale.
Okay. It is used to measure the volume or amount of oxygen whilst you breathe in. Okay. So in the incidence spirometer, when you use it 10 times a day and you are always using it to breathe in, it will expand the lung, it will expand the air because consistently air is getting its way to your lungs. Because this incidence spirometer, it helps you to get air into your lungs. It opens it up. So if someone has pneumonia, you teach them that use the spirometer 10 times if in an hour once you are awake, because it measures the volume of air once you inhale. The more you inhale, the more the air enters, the more it opens up your lungs. Are you getting the issue or the technique? Okay. All right. The next point, cough and deep breathe every 2 hours. Example, using the half coughing technique. The half coughing technique. Who remembers the half coughing technique? And then let me even ask, what is the function of the half coughing technique? Or what helps you to achieve when you do the half coughing? Yes. What does it do? Oh.
But actually, to bring out mucosa.
Is it?
To bring out mucus.
It brings out what?
It helps you to bring out mucus, like
Secretions
phlegm.
out. Okay.
Yeah.
Yeah. And then what is the function of paisley breathing?
To bring out carbon dioxide.
Bring that carbon dioxide. Okay, good. So paisley breathing brings out carbon dioxide, whereas half coughing brings out secretion. So you need half coughing in this procedure. Okay, you really need half coughing in this procedure. And I told you that in the half coughing, you don't really cough forcefully. You just assume like you are mentioning the word WHO, like who. So you do something like who, who, who. You don't do no, that is coughing. But in half coughing, you just do WHO. You just bring the secretions out. Okay. So that one too can be used in this technique. Okay. That one too can be used in this technique. So please take note. Okay. Please take note. Okay. Please take note of that. All right. Next point, chest physiotherapy to help break down thickened secretions. So sometimes they can do what we call chest physiotherapy. Okay, the chest physiotherapy helps you to do what? To bring secretions out. Okay, it helps you to bring secretions out. So sometimes they even have a vest. The vest begin to compress your chest till the secretions comes out. So all those things goes under chest physiotherapy. Okay, all right. Then position patient with the affected lung up. Position patient with the affected lung up, meaning that when a patient comes with pneumonia and the right lung is affected, the right lung must come up. There's a rationale. See, imagine that you have pneumonia and the pneumonia affected your right lung. And then you place the right lung down whilst you are asleep. What do you think is going to happen? You are compressing the lung. Already, we need air to enter that lung for adequate oxygenation. And then you are sleeping on that affected lung. How can the air enter? So usually, you sleep with the affected lung up so that air can enter. The one that is not affected, allow it, for that one is strong. So even if you have small air enter that one, air can give you proper oxygenation. But the one that is getting damaged, it is getting inflamed, and you slept on that one too. How will the air enter? So that's the rationale. So you need to sleep with the affected one up. As clear as that. It's easy, right? Good. Then next point, avoid the use of over-the-counter cough suppressant. Okay, avoid the use of over-the-counter cough suppressant. Why should we even take cough suppressant? We need you to cough to bring the secretions out, and you are suppressing it. It is not advisable, right? Yes. Then next point, use a cool mist humidifier, like something that can warm your air you breathe. Because when the air you breathe is becoming warm, it can dilate and then sometimes help you to breathe, especially when I give it oxygen. Okay, we give humidifier so that it can help you breathe in the oxygen properly. Okay, so that is something. Use a cool mist humidifier for the patient. Okay, so that is something that you should know. Then lastly, eat high calorie, high protein diet to help the patient build their weight. All right, pharmacology. Pharmacology. You can give them antibiotics. So antibiotics are used to treat bacterial pneumonia. Antiviral medications are used to treat viral pneumonia, right? And antifungal for what? For fungal pneumonia. Okay. So that is that. So you can give ceftriaxones, you can give clindamycins, azithromycins can be given, and the rest. Okay. All these drugs can be given to help the patient. Then 3, antipyretics for the fever. Antipyretics for the fever. 4, IV fluid, usually normal saline. Okay, you give them IV fluids because we need hydration to thin fluids. Okay, all right. Then lastly, you can do what? Influenza and pneumococcal vaccine. But please take note, you have to take your blood sample for culture and sensitivity before starting antibiotics. Because if you start the antibiotics, they will go and destroy, and it will not help you get the right isolation for the causative organism. Okay, so always take the blood sample before you start the antibiotics. All right, good. Complications of what? Of pneumonia. There can be pleural effusion, there can be sepsis, and there can be empyema because there are exudates in your lungs. There are exudates in the airway. So if care is not taken, and then maybe your lungs rupture, the fluid in your alveoli, in your lungs, can spread to your pleural space, can get pleural effusion, can get empyema. And then pneumonia is an infectious disease, or let me say, you get by infection of the lung. So if you don't treat the condition as soon as possible with your antibiotics, with your antiviral, with your antifungal, what is going to happen is that you can get septic or septic shock. Okay, so that is that for pneumonia. Any question on pneumonia? Any question on pneumonia?
Yes,
So,
Dr. Kite, please, Dr. Kite, please, is pneumonia a airborne disease or droplet?
Okay. Oh, pneumonia. It is not really. I mean, well, sometimes. You see, it's a bacteria something, okay, but then it is not airborne. It is droplets. Sometimes we classify it as part of the droplet conditions, okay. True respiratory droplet, like if you cough, something like that, okay. It is not really airborne. We can classify it as droplet, but hardly will you get those questions for pneumonia. But then if you get it, you pick droplet for pneumonia, okay? You just pick droplet for pneumonia, not airborne. So droplet for pneumonia, okay? Droplet for pneumonia. All right, next question.
But
Next
like,
question.
so please, mostly, is it the last that will give us a clue that it's pneumonia? Because it looks like the symptoms are a bit similar to the others, except the
Yes,
increased capsule parameters.
yes.
Is it
So
the increased white blood cell that will be?
increased white blood cell, high fever, and then infiltrate on chest X-ray. Okay.
Okay.
Yeah. This will tell that the patient is having pneumonia. Okay.
All right.
Infiltrate, increased white blood cell, high fever. Okay. Yes.
Okay. All right. Thank you.
You're welcome. All right. Mami Boacho, yes.
Sir, please, you said I think from the intervention,
Uh-huh.
you said suppressant not given. Can cough mixer be given like the expectorant be given? Or
Expectorant is
pneumonia?
different from you finish. I'm listening.
Yeah, I want to ask if like cough mixture like expectorant can be given those ones that can bring the foot and milk
Yeah,
help
help the
the
mucus come out. Yes, yes. You can give expectorant like guaifenesin. Guaifenesin, most common for the NCLEX. Okay, guaifenesin can be given, but then please, before you buy any cough suppressant, before you buy any cough mixture from the over the counter, please speak to your doctor first, because some of the cough mixture they contain some chemicals that is not good. Okay, so that is it. Okay, so you can take the guaifenesin. Okay, guaifenesin for expectorant to bring the mucus out. Yeah, it is possible. All right. All right. Any further question? Any further question? Any further question?
say hello sir.
Yes, please. I'm listening.
Please, so this question is not about today's one. Can I ask or after the answering of the questions then I ask?
You ask. You ask your question.
Please, yesterday, concerning the chest tube, you mentioned that when the tube dislodge
Uh-huh.
from the chest,
Uh-huh.
you have to put a glove hand to cover it
Mm-hmm.
before you put the sterile gauze to cover the place
Uh-huh.
before the insertion can be done.
Mm-hmm.
Please, that's for the video I watched concerning that. I quite remember it. The woman was saying that when it happens like that, and maybe it's a post procedure within 6 hours, you can reconnect it, the tube. But after 6 hours, that's like within 12 hours from the 6 hours to 12 hours, you can't reconnect it. I
Okay.
want to know how maybe I didn't get the statement well because since yesterday I've been contemplating about it.
Yeah, yeah,
Thank
yeah,
you.
yeah. You reconnect to, but then the first thing you do is to first put your gloved hand whilst you prepare to reconnect. Okay, because the reconnection is not easy. You are waiting to even probably try to clean the tip of the tube or even get a new sterile tube. You try to get a new sterile tube, and then you are saying that like, okay, let's wait, let's not cover, let's wait to reconnect. No, you have to cover once you prepare to reconnect, so that the air will not enter the space. Because if you leave the area like that, and it will allow air to enter. So that is the point. I don't know if you are okay.
Hello, sir.
Yes, I
Yes.
got that.
I think you're not getting her question.
Eh.
Yes, please. So let her clarify again so that you can give us the answer.
Okay, Mami watch. Yes, I'm listening
What
again.
I got the place that it's very needful for you to cover the place to prevent more air from to
Mm-hmm.
enter the chest. I
Mm-hmm.
understand the place perfectly. But
Uh-huh.
from the video of the woman, she was saying that within 6 hours, like you can immediately connect the tube to the chest because the place is not so dried. But
Okay.
after 12 hours, the place has become dried or something like that. If
Mm.
I stand to be corrected, that's what I got confused about yesterday. What you're describing. Thank you.
So if I'm getting you, do you mean that? Hmm, Do you mean that like you want to find out, can you reconnect chest tube despite after 12 hours or less than 12 hours or 6 hours? Like you want to find out that or what?
Yes, she was, from what I understood her, like within the 6 hours, you, the nurse, can clean the tube with a sterile, hours, unless the doctor or the surgeon does it. That's what I got a little bit confused about what you were saying yesterday.
What did I say yesterday that got you
If
confused?
you
What did
Yesterday
I
you
say?
were saying that like reconnect. You were saying about the reconnection of the tube, but you didn't specify. Maybe like after some hours, you the nurse can do it, or the healthcare provider have to do it. Because from the woman's video, if I remember, she was saying that like the nurse can reconnect it. But after to provider, so you have to cover the place and then notify the healthcare provider for the tube to be reconnected, whether a new incision has to be done or something like that. Oh, okay. Someone is saying that one is talking about the tracheostomy. Oh, okay. 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 Thank you very much.
But Aki, I think that that one applies to tracheostomy where they have a matured and then the young this thing. So you have to check. So
I'm
I
even
think
confused.
what she's talking about is about tracheostomy too. I
Okay,
don't know.
Okay. Thank you very
anyway,
much.
anyway, because but all the same, okay. Okay. So anyway, because me, I know when a tube is out for a chest tube, you just have to place the gloves and you don't worry. But for that time, I think the timing, yeah, as they are saying for tracheostomy, when it comes to the chest tube, they don't really have that healthcare provider, that 12 hours, 6 hours thing, 7 days, 7 hours. Okay, so you just stick to what I gave you because I have not really come across that one. Okay, okay, so you just stick to what I gave you. Okay, if I found any information on that, I'll let you know. I'll let the class know. Okay, on the timings and the rest. Okay, all right. So let's do some questions on my screen and then we can end the class for today. So someone should read for us. Anyone to read for us?
Okay. An older adult with residence in a long-term care facility becomes confused and agitated, telling the nurse, "Get out of here. You are going to kill me." Which action will the nurse take first? A. Check the resident's oxygen saturation. B. Do a complete neurological assessment. C. Give the prescribed PRN or lorazepam. Then D. Notify the resident's primary care provider.
All right, yes. Hey, no answer. It's an older adult who is getting confused and agitated. What should you do? Do you think it is something about neurology or about oxygen?
Say B.
But I think the assessment first.
Answer is A. I think I said this. Oh,
Yes, yes, yes. You said it. You said it.
So the answer, I think I told you that if they have poor oxygen to the airway, they can get confused, right? In the older adult. So I think I told you this. So it should be A. Next question. Yes, please. Next question.
An older adult patient presents to the ED with a 4-day history of cough, SOB, pain on inspiration, and dyspnea. The patient never had a pneumococcal vaccine. The chest X-ray shows density in bilateral lung bases. The patient has wheezing upon auscultation of both lungs. Would a bronchodilator be beneficial for this patient? A. It will not be beneficial for this patient. B. It will help decrease the bronchospasm. C. It will clear up the density in the patient's lung bases. D. The patient will have a decrease in the pain on inspiration.
Okay, what is the answer? B. I see B. I see B, 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 B. Okay. All right. Let's see the rationale and see if it is B. All right. So bronchodilator will help open up the airway and help decrease the bronchospasm. Obvious, right? Okay. Next question.
A patient being admitted for pneumonia. The sputum culture is positive for streptococcus, and the patient asked the nurse how long the treatment will be. The nurse knows A. The patient will be treated for 5 to 7 days. B. The patient will require IV antibiotics for 7 to 10 days. C. The patient will complete 6 days of therapy. Then D. The patient must be affable for 24 hours.
Yes.
B.
B. I want to be saying A. But how long do we give antibiotics? Minimally
14 days. 14 days.
14 days.
Mm-hmm.
Yeah.
Or 7 days. Okay.
The minimum is 7 days. It's serious
7 days.
infection.
7 days.
Yeah. So it's serious infection that will continue for 14 days. Okay. And sometimes up to 21 days. So
Okay.
actually, when doctors are prescribing antibiotics, they give minimum for 7 days. So the answer is A. All right.
Okay.
Next question. Next question.
The nurse noticed a visitor walking into the room of a patient on airborne isolation with no protective gear. What does the nurse do? A. Ensure that the patient is wearing a mask. B. Tell the visitor that the patient cannot receive visitors at this time. C. A particulate air respirator to the visitor. D. Give a mask to the visitor.
Yes. Airborne. 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 What should you do? You're not wearing a mask. Airborne. Yes. C. 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 All right. All right. So C. D. Are you surprised? Let's see the rationale. So because the visitor is entering the patient's isolation environment, the visitor must wear masks. The patient typically must wear a mask only when he or she is outside of an isolation environment. Turning the visitor away is inappropriate or unnecessary. It would be necessary for the patient. It will not be necessary for the visitor to wear an air respirator. So just give the patient the visitor a mask, okay? Some of these questions I understand. I mean, they are not
Please
clear.
go back. Go back to the question, please. So what marks are we, just a surgical marks, or what marks are we giving to the
It
patient?
should be airborne. If you are entering a patient room with airborne, it should be N95, whether nurse or visitor. It should be N95. As I'm saying, some of these questions, where I pick them from, they can sometimes give some little confusion, but it's normal.
Okay.
So don't worry. Okay. They need an N95.
Yeah.
Okay. So the answer C or D would be correct. Okay. Don't worry.
Okay.
Last question. Then we close for the day. Last question. Let's finish hard.
The nurse knows in caring for her ventilated patient that the goal is to prevent VAP. She identifies the following as important in reaching this goal. Select all that apply. A. She should avoid wearing jewelry. B. HOD should be up. Head of the bed should be up. C. Administer chest physiotherapy. D. Provide oral care every 12 hours. Then E. Hand hygiene.
Yes. What should you go for?
B, C, E.
B, C, A. Should you wear a jewelry? E, B, C, E. But what about A?
She should
Should you
avoid
wear
wearing
jewelry?
jewelry.
Should you wear jewelry when on a ventilator? I see B, C, D, E.
I don't know.
I don't see the correlation with
That
the
one I don't
jewelry.
know.
I didn't choose them.
I don't see the correlation.
They said we are preventing something, so
You are preventing ventilator associated pneumonia, meaning
so
infection
if the patient
or
is wearing jewelry,
aspiration.
would they affect? I don't know.
Okay, I see. Let's look at the rationale. So the answer is A, B, E. Answer is A, B, E. Okay, answer is
I
A.
remember.
Why jewel?
I remember.
Why jewel?
Nurse.
The
That
person who wear jewel.
man,
I
what
don't
is his
understand.
name?
He said,
Oh, simple
yes, one at a
nursing man.
time.
Sir, please, I remember the simple nursing man said something about this oral care and VAP. I don't know if anybody remembers when
You don't provide the oral care every 12 hours. It should be every 2 hours. That is
Every
why
2 to 4 hours.
Yes, that is why it is wrong. Are you okay?
Yes, sir.
The jewelry, yeah, we are waiting for the explanation.
The jewelry.
Yes, the jewelry.
Yeah. The rationale is that when you wear jewelry, saying whilst on ventilator associated pneumonia. Okay. Hey, sorry. What did I even say? I said that when you wear a penicillin jewelry, when you wear jewelry whilst you are on ventilators, okay, it has some a rare this thing. Okay, one thing is that jewelries can hold bacteria. You know, when you wear jewelries for long, you see, for example, when you buy jewelries, initially you have a good color, then as time goes on, it changes color, sweat, infections. I mean, sweat, death, and then sometimes jewelries can harbor, or sometimes we say that jewelries is a carrier for bacteria. So rings, watches, bracelets, they can trap moisture and then dead skin cells, which can harbor bacteria and then dead bacteria that if you don't take care, you can begin to contaminate your skin and then can begin to lead to what? Can lead to ventilator associated what? Pneumonia. So when healthcare workers, especially those who wear rings, watches, wants to adjust the patient ventilator and change the tubing, sometimes the bacteria from the jewelries can directly be transferred to the patient respiratory tract infection, respiratory tract, which can lead to what? Ventilator associated pneumonia. Okay, because if the bacteria harbors the ring, harbors the watches, and then the nurse is about to change the tubing on the ventilator, the bacteria harboring in these areas can be transferred and they can be inhaled by the bacteria and can lead to ventilator associated what? Pneumonia and infections.
Why are we not doing chest physiotherapy?
He said,
why are we not doing chest physiotherapy in VAP?
It will cause aspiration because chest physiotherapy will bring sputum. And when on ventilator, you are not really coughing properly. So if care is not taken, the sputum that they are out of the physiotherapy because we are compressing the chest. So the physiotherapy bringing the sputum can cause the sputum into the, some way, somehow, or even saliva. Because the more you compress the patient's chest, the more you exercise the patient's chest, the more it becomes uncomfortable, even on the ventilator. The more it becomes easy for saliva, even oral substances to be inhaled into your patient lungs. Okay.
Okay, but Saki, I thought chest physiotherapy is a group of techniques that we do. So you can do posterior drainage, like positioning well. It's part of chest physiotherapy. It's not only the coffin and the half coffin that is chest physiotherapy.
Yes,
right?
yes.
So posterior drainage is also chest physiotherapy. So if you position the patient well in VAP, that one will help. Will even help. And we are only concentrating on the coffin aspect.
Exactly. So chest physiotherapy could mean a lot of things.
Yeah, so the posterior drainage is part. So
and then this thing is part. Bringing secretions and other things to it is also part.
Is also part.
So it has an umbrella. It's an umbrella. What do you call it? It's an umbrella point. So in this instance, if you take down one, it could also mean that secretions, which cannot be good for the patient. Okay.
Oh, okay.
Yes. So that is something you should know.
All right. Thank you.
You're welcome. Okay. So the answer is what? A, B. Wait, let me see. And the next knows in caring for ventilator patient is prevent. Oh, but you even get me confused. Anyway. All right. The next topic is pulmonary embolism. So we will treat that one next week Friday. Okay. But please, the question, you see, check the question very well on my last screen. C is not part of the question. The answers were saying that which of them should you not do to prevent, or which of them should you do to prevent? Am I lying? The nurse knows that in caring for a ventilator patient, that the goal is to prevent VAP. She identifies the following as important in reaching this goal. So if you want to prevent, okay. If you want to prevent, you don't, you avoid wearing, head of the bed. All right, I understand. AB, all right, I understand. Okay, all right. So that is it. So the next topic is pulmonary embolism. Okay, pulmonary embolism. Okay, pulmonary embolism. All right. Any question for today? Any question for today? Whilst we close. Any question for today? Whilst we close.